Hey guys, welcome back to the Foam Frat podcast. Happy Thanksgiving. Hopefully everybody's having some some well-spent time with the family. And we got a really cool episode today. So before we get into that, just a couple little announcements. So the first one, got some exciting stuff. So the first one is that starting yesterday, all the ways until midnight on Monday, so Black Friday through Cyber Monday, we are offering 40% off our courses. And so what you get is the EMS refresher, the 150-hour self-paced plus the live classes 5 days a week, the 12-hour mechanical ventilation course, the scan artist course, the critical care module, the 24 hours of critical care that's in there, and the educator's atlas, all for $95, $95.99. You know, you got to have that 99 in there. So you don't need no coupon. You just go follow the link. It'll take you there and you'll get all of this stuff for $96. So if you guys are a fan of the show and you want to support the show and get CAPC accredited hours, or if you're a nurse, ENA accredited hours, definitely go check that out. We'll put a link to that in the show notes. The next one is a new one we got going today. Sam, what's going on with this one?
Yeah, so we're doing a 3-pack of the cards. So this one it doesn't have the price on the video that we're looking at right now, but usually the cards are $11, and so we're doing a 3-pack for $20. So shipping
Man,
and
look how
shipping
festive
included.
that looks, man. Did you do that yourself?
Me?
Yeah. Look at that.
Oh, this was a stock photo somebody made.
Yeah, man. You can't even see the lines. That looks awesome, man. All right, so let's get into the actual podcast. So I'm going to introduce you guys to Matt Schneider. Matt is a battalion chief for Mequon Fire Department. Super smart guy, and he sits on the committee that changes up their guidelines for Ozaukee County, which is where pretty close to where Sam and I used to work. We just brought on, and this is the first time we've ever done this, but we had a medical direction, like a hospital system that looked over 8 different fire departments, EMS departments. And so they said, we want to use Foam Frat for the education for all of these different departments and utilize that learning management system to upload their own stuff and track and assign content. So Sam and I went out to the fire department to show them how to use this software, how to use Foam Frat Studio, the new LMS. And we just so happened to hit it on a night where they were talking about their guideline changes. So after we got up and did our little spiel, Matt got up and was talking about some of the changes they made to their guidelines. And really, I thought they were really progressive changes. And what I liked is sometimes I think maybe we confuse progressive with getting to do more stuff, but sometimes we actually take something away if it doesn't make sense to do it. And they mentioned how they removed Nitro from their Stemi Guideline. And immediately my ears perked up because this is something that I've looked into. We have the Nitro Solving for X lecture that we do where we talk about, maybe sometimes we should be giving analgesia instead of Nitro. And I don't want to get too far into it because we had a really good discussion on it. So what we're going to do is we're going to roll that podcast or that interview with Matt Schneider. And then Sam and I are going to follow up on the back end because we don't want to, give it all away right away in the beginning.
This is an interesting one. So I feel like if we get into the weeds on this, it might ruin the foundation of what you guys talked about. So yeah, we should lay the foundation first, and then I've got some interesting talking points for this one.
Yeah, we don't want to spill the beans. So all right, let's roll to it. And Matt Schneider, tell us about yourself.
Yeah, so my name is Matt Schneider, and I'm a battalion chief of EMS for the city of Mequon, which is a small little fire department that handles EMS as well in southern Ozaukee County, Wisconsin, which is kind of in the greater Milwaukee area.
Awesome, man. Yeah, and you're you run as a battalion chief, a paramedic there, and you guys recently made some changes to your guidelines. How often are you guys doing that, changing up guidelines?
Yeah, so this is kind of a new endeavor for us, but we certainly aspire to be a high performing EMS system, and one of the kind of hallmarks of high performing systems that go through guideline updates is to do it quite frequently. And also to do it in a evidence-based and collaborative manner by using a lot of different resources and minds that you can bring to the table. So we're on our probably third or fourth update at this point from our newer guidelines. And we do that at a committee, and we aim to do this quarterly. So actually quite frequently.
Awesome, man. Yeah, so we just partnered with your department as well as a bunch of other departments who are under a medical direction. And it was the first time we've done that where we had a corporate partner that said, hey, we have like 8 departments and we want to provide your online learning solution. And so Sam and I went down to Thiensville Fire Department and we were showing you guys how to use the platform. And we just happened to hit it on a night where you guys were going over some of the guideline changes. And I thought they were great. I thought the way you presented it was great. But there was one particular that I thought was really interesting, and that was you guys removing nitroglycerin from your Stemi protocol or your Stemi guideline. And I thought that was interesting because I had recently done a podcast with Dr. Steve Smith and Tom Boothole, where we talked about who gets a right-sided ECG. And we talked about V4R and does it really pay to put V4R on? And when you ask people, why do you guys do a right-sided ECG? They say, well, it's to determine whether or not we should give nitro, or maybe they're looking for like an isolated RV infarct. And Dr. Smith was like, well, first of all, why are we giving nitro? Like nitro has never been proven to have any benefit past like the reperfusion trials. And that was what a nitro drip. And so he's like, it really doesn't pay. There's no literature that shows that we should be giving nitro. So why are we doing it? And definitely don't do a right-sided 12 lead to see if you should give nitro. And it was like a small little like comment he made, but there were so many people that asked about that. And they're like, yeah, why do we give nitro? Let's just give aspirin, or, what about heparin? Why do we give heparin? And so when I heard you mention that you guys omitted this, I wanted to hear more about that conversation, because this wasn't just Matt Schneider's idea, right? I mean, this is an accumulation of minds, like you said, that got together and made this decision. So walk me through how you guys got to that point. Like, what was the first conversation piece that started that projection towards removing nitro?
Yeah, you're absolutely right. I mean, on multiple points there, it was certainly not just my idea. We're lucky to work in a system where we have a very interactive and involved medical director, Dr. Jason Stosko, and he comes to these kind of committee meetings with us also for these types of protocol revisions. And interestingly, we're really interested in how we train our paramedics, and we're always interested in expanding their ability to critically think. And one aspect of that is not only thinking about what you could do in the future, but constantly reviewing what you're actively doing and what's done by convention. And so a huge component of protocol updates is not always just looking into the future and saying, what can we do next? What's on the cutting edge? But it's also continually reviewing the stuff you do very commonly in common practice. And so at one of these meetings, we're all just kind of sitting around talking about guidelines that we're going to update as we go through. And we kind of got to this chest pain guideline. And one thing that we have to kind of strive to do as EMS system administrators, medical direction, and even all the way down to the field training officer level, is find ways in EMS to simplify things. And so we get to this chest pain protocol, which I'm sure everyone here is familiar with in their guidelines, independent of where you work. And I'm looking at it, I'm like, man, that is just a confusing guideline. like not only the differential chest pain, right? Like this broad differential of all these different things, also how to treat each thing, and algorithmically getting down to like, is it an MI? And going back to what you talked about with Dr. Smith, is it the right vessel? Is it the left vessel? And how does our treatment kind of differ? And I thought, man, that is just incredibly complicated for a system that has relatively short transport times to a PCI capable facility. And so Joe DeBoer, physician assistant, EM physician assistant, just phenomenal guy and a huge contributor to the success of our system, start talking about it with Dr. Stosko sitting there. And we're like, hey, should we really have a Stemi guideline instead of a chest pain guideline, or in addition to a chest pain guideline? And so that kind of sparked the discussion that gave rise to this change, which is essentially having two separate guidelines, one for ischemic chest pain and one for a patient who's actually got active acute necrosis, STEMI. And so those are the two different types of treatments that we're going to institute.
So, okay, so you guys have two. So you have an ACS guideline, and then you have like actually you see ST elevation. And the one that you remove nitro from is the one that you actually see ST elevation, right? Or am I saying that backwards?
Absolutely right. That's 100% the case. We said, you know what? So you got this patient who's complaining of chest pain. They're endorsing some type of chest pain that's going to lead you to investigate, is this cardiac? Is it not cardiac? And so now you're in this like chest pain bubble. That's your first kind of part of the algorithm. So now you're like, okay, is this ischemic chest pain? Is it a probable stable or unstable angina? Is it fall into the STEMI and STEMI type window? And if you go into that kind of diagnostic bubble, you're going to do a pre-hospital ECG, just a normal 12 lead at this point. Mm-hmm. And so dependent on the results of that 12 lead, whether it be by your interpretation as a paramedic or the computer interpretation as a non-paramedic, it'll tell you then if the patient's having active infarct. If they're having active infarct, you kind of then transition into the Stemi guideline, which changes how you're going to treat the patient. If they're not having an infarct, meaning they may have kind of an ugly ECG, they may have crazy stress changes, regionalized stress changes, kind of reperfusion like ectopy or whatever the case may be in conjunction with ischemic chest pain, you're still going to stay in this chest pain guideline. And so I think where it's helpful to kind of introduce people to this is if we go all the way back up in the chest pain guideline, meaning they have signs of ischemic discomfort, however, they're not actively infarcting on your first ECG, you're going to do pretty much your standard ACS care that we were all taught in our education as paramedics. So you're going to give them oxygen if they're dyspneic or hypoxemic and titrate it. You're going to evaluate for mimics or other possibilities within the chest pain differential. You're going to evaluate them for a candidate for aspirin and administer oral aspirin. You're going to establish access, do serial 12 leads, and consider giving them, if there's no contraindications, a dose of sublingual nitroglycerin. And we can do that up to 3 times still every 5 minutes. However, if at any point you see that they're infarcting, they're having a STEMI, we go into this complete new guideline. So the new STEMI guideline says that if the person's infarcting, it doesn't matter where you localize the lesion to be, you're going to establish IV access, administer aspirin and oxygen if it's indicated, and then you're going to place the defibrillator pads on the patient, anterior, posterior, and you're going to activate PCI and rapidly transport the patient. And at no point should you really consider nitroglycerin. Now, once you're underway, if the patient has significant discomfort and requires analgesia, you can certainly use, IV fentanyl for that management.
No, that makes sense. So essentially, you guys came to the conclusion that there's more complications associated with giving a STEMI patient nitro than there is benefit. And it's interesting because when I'm going to pop this up real quick. This was a study in the pre-hospital emergency care journal. And they looked at pre-hospital nitro safety in inferior ST elevation. And even though you guys aren't just saying inferior, you're saying all of them, that makes a lot of sense. Because if you look at this study, what they found is that 38 out of the 466 became hypotensive, which they defined as like a systolic less than 90 with an inferior wall MI. So that was 8.2%. And then all other MIs, 8.9%. So there was really no difference between an inferior wall MI or all MIs. And you can see about 8.9% of those still had that drop below 90. And then they looked at a drop in systolic greater than 30 because, maybe you were at 180 and then you dropped to 120. That's still a significant drop, but it wasn't less than 90. Same thing, 23.4% in inferior and then 23.9%. So they concluded by saying nitroglycerin administrations to patients with chest pain and inferior STEMI on their computer-interpreted electrocardiogram is not associated with a higher rate of hypotension compared to other STEMIs. And that makes a lot of sense because that's exactly what you guys are saying as well. It's like, hey, some patients are going to become hypotensive. It probably doesn't matter where that MI is. they're still going to become hypotensive. And the best way to know probably is their blood pressure. And so that kind of segues into another thought that I had with this. And that's most nitro guidelines are predicated on a systolic, right? So like they got to have a systolic greater than 90 or 100 or 110, whatever they decide, right? And coronary perfusion is basically all diastolic, right? I mean, that's the majority of it is during diastole. And so when you see somebody with a blood pressure of 100/50, and like a normal coronary perfusion pressure, right around 50, right around that range, you start seeing like, okay, if let's just imagine your heart is infarcting and you have reduced ejection fraction, and then the ventricles are actually starting to like get full with blood, right? So they're starting to swell up because you're not ejecting as much out with during systole. That's pushing on the walls of that ventricle and making it harder for the coronary blood flow to go through. So you're almost increasing the resistance. And so maybe if you have a diastolic of 80, that's enough to still perfuse some of that area. But if you drop that diastolic down to 50, and you have to subtract that left ventricular end diastolic pressure, which is just the pressure of the fluid pressing on the walls, you can see why that would not make sense to do that. You would not want to drop that diastolic pressure that much. And I have seen situations where somebody gets a dose of nitro and the ST elevation actually looks worse because they drop that diastolic pressure and they reduce that coronary perfusion pressure. And so even in the patient who has ACS, who you guys are still saying if they fall within these parameters, I still find I think if I go in and I see somebody's got a pressure with a diastolic of like 60s, 50, 60, going to like nitro or fentanyl probably is going to be higher on my list than doing something like nitro. What are your thoughts on that?
Yeah, man, let me unpack all those thoughts. There's so much in there that I can completely echo and agree with. I mean, you first touched on, the literature you brought up. So certainly in these changes, we do some deep dive type literature reviews, and you're absolutely right that there are some good pre-hospital studies like the one in emergency pre-hospital care that you presented that were really well done and very meaningful conclusions. However, there is currently not, at least that we can find to 2020, a really robust, multi-system, double-blind, academic center involved study that looked at giving nitroglycerin to patients by paramedics in a pre-hospital environment who are actively infarcting, independent of the region of their infarct, and their actual reduction or benefit to morbidity and mortality. Most of these endpoints, like the one you presented, are looking at blood pressure, drops in systolic, drops in MAP, drops in diastolic, or changes in pain level. And so none of those things really help us determine, are we actually helping the person reduce their mortality? So that's kind of the first issue that I completely agree with. Certainly, as any system should be when we're looking at reviewing our guidelines, we're always open to new information. So as soon as that awesome study comes out about giving sublingual nitro to pre-hospital STEMI patients and looks at their 30-day mortality, then we're completely open to changing these guidelines. And it's very easy to do. The second thing you talked about is using systolic as kind of your surrogate assessment finding to determine if the person's a candidate for this really super potent veno-vasodilator, more veno-selective than vaso. And so I completely agree. I always teach my paramedic students that, your diastolic blood pressure is comprised of your V's. So your viscosity, your vascular resistance, or your vascular tone, and your volume. And so all of those V's are affected by the medication nitroglycerin. Certainly when you're giving it sublingually and the absorption and metabolism and distribution is kind of unpredictable at such a high dose, 400 micrograms, you're definitely going to drop that person's diastolic pressure far before their systolic. Actually, it's the drop in diastolic that's going to lower their systolic pressure. And so the question is, if the left coronary artery is perfused by diastolic pressure, then why are we looking at systolic pressure to decide if this person needs nitroglycerin? And so I completely agree. If that person is diastolic's kind of soft at 50, but their systolic's 130, and that makes them a candidate for nitro, The question should really be, should you be giving that patient nitroglycerin? Because you're going to have a dramatic reduction in their coronary perfusion pressure. And so it's very, very important to consider that, particularly in the right ventricle. The right coronary artery kind of behaves very uniquely. It gets kind of perfusion throughout the cardiac cycle as opposed to the left coronary artery. And so when we're messing with those diastolic pressures on the right side, it's a recipe for disaster, I think.
You mentioned that because you guys are so close to a cath lab, that was one of the factors as to why you guys removed nitro from STEMI. Do you think that there's a certain distance that you would say maybe we should be giving it, or is that really not a thought?
It's a great question.
This is kind of figurative because you guys are closer.
Right.
But let's say you got a 40-minute transport. Do you think there's any benefit there?
It's a great question. I mentioned our medical director, Dr. Jason Stosko, who's just incredibly pragmatic and open-minded and kind of understands what we're dealing with in the field. And so it's funny, as we're having this discussion, Joe DeBoer and I, early in the inception of this guideline change, Dr. Stosko kind of reports to us like, hey, I quite honestly, like, STEMI walks into my ER, like I get them aspirin, I keep an eye on them, and I call cards. Like I'm not giving them nitro in the ER either. I work in a PCI capable hospital. And so, these hypotensive effects that could happen have a much more impactful, negatively impacting event on the patient's morbidity and mortality. So why even mess around with it for some potential benefit that we're not quite sure of yet? And so the question is, if you're far from that destination, should you try these therapies? And I don't know if I can really speak to that or have an answer to it. I'd love to know if there's a time-dependent type issue here. What I will say is that these are guidelines, and so all of our paramedics have been trained like, hey, if you have that unique patient, they're infarcting, but their pressure's 218 over 112, and they're having a LV infarct. Do you think it's the chicken or the egg thing? Are they having, increased peripheral vascular resistance because of their low cardiac output and they're getting hypertensive? Or is this kind of like a blood pressure, causing this kind of myocardial distress? And could this patient benefit uniquely from some afterload reduction with sublingual nitro? And so we want to leave it open for people that if they experience that kind of unique patient, they can still call med control and have that discussion and say, hey, you know what? I think this guy's worth a trial of a sublingual. And so I think that in those types of situations, it might be beneficial. But I think the argument can be really, really strong that if you're doing that and you have the capability to, and you got IV pumps on your truck, you should probably be doing intravenous nitro that's titrated to some type of blood pressure goal.
That was going to be my next question. Do you guys carry nitro drips?
Yeah, absolutely. And this was a caveat I wanted to mention, so I'm glad you brought it up. I am not a nitro hater. We are not nitro haters. Nitro is a phenomenal, pretty cool drug. And so it's got incredible benefits for, cardiogenic pulmonary edema with hypertension or the escape syndrome that I'm sure many of the listeners are familiar with. And so the benefits here are incredible. And so we're using either high dose sublingual for that type of patient presentation or push dose intravenous for that type of patient presentation. So I think the availability of IV nitro and the cost reduction in IV pumps can really expand people's accessibility to IV nitro. And I think that in the future, hopefully that's the way that we're all doing it.
Why don't you guys just use nitro paste, man?
Yeah.
I don't know. Yeah. Nitro paste was, I don't know. That was told I remember in paramedic school, the only time we ever talked about nitro paste was if you didn't check the patient's back, they automatically had like 4 inches of nitro paste on, and that's why they were hypertensive. But
yeah, some kind of crazy.
Yeah. But when you look at the literature on giving a diaphoretic STEMI patient nitro paste, it's a joke. Yeah, it's not even.
Yeah, and it's really bad if the patient confuses it with their hemorrhoid cream. That's just a terrible outcomes there. So
horrible. Horrible.
Yeah.
Awesome.
So I think, to your point, I think IV nitro is the way to go. And I think that titrating it is probably way more appropriate. Like you said, a lot of those studies in the literature, they're more looking at the in-hospital use of intravenous titrated nitrates with an ART line, and so to use those things and say that pre-hospital sublingual at the point of insult is the best thing to do is probably a gross extrapolation of their findings. So hopefully in the future, all those medic units out there start using intravenous nitro.
Yeah, the pumps are getting cheaper, and I think they're only going to get more robust as far as EMS goes. I know sometimes, like on interfacility transports, like paramedic crews will just take like the facilities pumps with them, and that's, I think that's like a recipe for disaster if you don't know how to use
100%.
that pump, and
Yeah.
they're not rated for transport and they're bouncing up and down. So yeah, I totally, I'm a huge advocate. We did a video for Sapphire and we tested out the Sapphire IV pump, and we don't get any money for saying this, but that's the one we just switched to, and I like it a lot. I think they're pretty affordable, and then running that nitro drip is nice because you can just turn it off. I mean, you think about how much you're giving in a sublingual, because like if I start a nitro drip, let's just say I start off at like, I don't know, 40 mics a minute or 50, 60 mics a minute. Not on escape I go higher, but just ACS. Sure. That's still like when you compare that to a sublingual where you're giving 400 micrograms, just a shot of it at once, you still have a lot of room to see how that blood pressure is going to behave before you get to that 400 mic point, where before it's kind of just like full send. And what's funny is they give little grandma a bottle of those things to go home with and take them if she's got any chest pain. And so you may arrive and they've already taken 2 or 3 of those.
Yeah. Or they've got, a super dry mouth. And when they go to lift up their tongue, they got 3 sitting under their tongue that haven't, dissolved yet. And so they're just waiting to tank. Oh, all the time. And,
really?
And we still use tablets like for sublingual. I know most people are on the spray, but, we can't really afford it. The spray is incredibly expensive. And so, you'll jam these tablets under people's tongues, and then you lift it up, 5 minutes later for their next dose. And it's like, oh, you didn't even get the first one, it didn't even dissolve yet. So I think that these are all contributing factors to the kind of like unscientific, just kind of haphazard use of this drug in these very delicate patients. And, I think the more you study physiology and medicine, you realize that the human body is incredibly like complicated and delicate in its own preservation of insult. And so I think what's really unique about paramedics is we're responding to these patients having myocardial insult at the time of injury. And sometimes it's happening right in front of us with the increased frequency of serial 12 leads. And so you're seeing them actively infarct, and now you're going to give them this medication that's going to mess up, their coronary perfusion pressure, potentially some of their autoregulation and their myocardium, all kinds of things. Their PaO2 is going to be manipulated because of the pulmonary vascular effects of the drug. So there's just tons of things you're messing with the normal physiology. And so maybe the best thing to do for these people is to just keep an eye on them for deterioration, whether it be bradycardia, hypotension, or VF arrest, and get them to a capable facility as quickly as possible.
Yeah, I like how you mentioned getting the pads on them. We even put the back plate of the Lucas on just because we're like, I don't want to be doing this in flight. Let's get them all set up. Let's be prepared. And, maybe sometimes less is more. We're going to take the guideline, if you guys are cool with it, and post it in the show notes.
Absolutely.
For this podcast. And if anybody has any questions, what's a good way of getting a hold of you, Matt? Can we give out your email or?
Yeah, it'll be fine putting my email in the show notes.
Yeah, I'll just put it in the show notes.
I'm sure you guys have such a audience that I'm sure there's somebody out there who's got some interesting thoughts on this. There's some literature we might not have reviewed. And so I'm always happy to lay eyes on that stuff, kind of think about it and present it to the powers that be and kind of the more important decision makers than myself.
Yeah, and if anyone else out there has anything that's different that you guys are doing with your guidelines based off of evidence or based off of lack of evidence in this situation, let us know, because we'd like to do a segment where we talk about guideline changes that are maybe a little bit different, a little abstract, and how those are working out. So definitely hit us up, team@foamfrat.com. Matt, I can't thank you enough for your time, man. Thanks so much for coming on.
Oh, yeah, man. It's been awesome, and thanks for having me on.
All right, welcome back. So we're going to talk about some of the points that Matt and I talked about in that podcast. So Sam, I know you had some questions that you were kind of stirring up and thinking about. Lay it on me. What's some of the stuff that popped into your head while you were listening to that?
Yeah, so the first thing that I thought about was you guys were speaking about left ventricular end diastolic pressure versus the diastolic blood pressure, because that's the difference between those two is what gives us our perfusion pressure, our coronary perfusion pressure. And I was thinking that, most people are using oscillometric blood pressure cuffs. So I think we're all pretty comfortable with some of us more comfortable than others than with the blood pressure that you get from an automated blood pressure cuff. And so you guys are talking about, why do we titrate off of systolic? And that's a completely valid point, which you and I have long thought about. That's not really the number that matters the most in that equation. So why not use diastolic? But I was thinking with those oscillometric blood pressure cuffs, the automated ones, the only number that they directly measure is MAP. And your MAP is made up of 2/3 diastolic blood pressure, and it's the most accurate measurement on those oscillometric blood pressure cuffs. So I guess my question is, pre-framing that, do you think that MAP would be a good surrogate to replace systolic blood pressure, since the systolic and diastolic are usually calculated on those machines?
Yeah, that's such a good question. Even though I know that those oscillometric blood pressures aren't actually measuring systolic and diastolic, I got to remind myself that on like a daily basis when I'm on shift, because it's so easy just to look at it and say, yeah, my systolic is 120, my diastolic is this. So just to kind of go back a little bit, the normal MAP equation is predicated on you spending 2/3 of that time in diastole, right? But that's completely predicated on your heart rate as well. Because if somebody's tachycardic, they're not going to spend that 2/3 of that time in diastole. It's going to probably favor the systolic side. And so I think I have in the past, when I first learned about this, I have said that, yeah, these automatic blood pressure machines calculate a MAP and then they extrapolate a systolic and diastolic from that MAP. But if you look, and there's actually some studies that show this, it's not using your standard MAP formula. It's not that simple. It's looking at your maximum amplitude, and then there's this whole algorithm it goes through where it weights systolic and diastolic. And it's not the same as how we would calculate a MAP off of like a manual blood pressure. And so I don't know, even saying that, like, yeah, I want to believe maybe it's more accurate. But if you look at, like, I've transported patients that have an art line in, and we're also taking a blood pressure on just manual blood pressure as well. And you'll look and you'll see the maps are correlated somewhat. But if you try to get to that map using the numbers that they have, it doesn't work out that way. And so there's some weird voodoo equation that they're doing. And even if it was actually the map, I don't know what map I would look for to give nitro. I don't really know how I would weigh that out. So I think I have more questions than I have answers for this. I know it's not the standard MAP formula, that 2/3, because it doesn't always equal out to that. I know that most commonly they're using maximum amplitude, and then they're looking at the ascending and descending portion of that curve, and then they distribute a weight to systolic and diastolic. I don't know. You probably could just take a manual blood pressure, at least one, and then like look
Don't
at
tell
that.
anybody, man. Why are you ruining everybody's party right now? Saying we got to take a. No, I did. Do you remember that blog I did on that a long time ago? It was called the Map to Clarity.
Yeah, that was like one of your like first or second.
Yeah, that was an OG foam frat blog, but I went deep on that formula for a heart rate corrected MAP. I talked about MAP, and then I talked about the heart rate corrected thing. It wasn't a huge difference. I tried to because when I initially got into that equation, I was thinking, ooh, like if you have a super tachycardic or bradycardic patient, this thing will change like crazy. It wasn't, I don't know. It did change for sure. And I have the equation that they use in that blog. It wasn't crazy though. So I don't know. I agree with you though. There's more questions than there are answers, because you can't come out and say like, well, in that case, this map would be good. We have no idea what that number is, because there's so many different combinations. But just a thinking point on that one, because I agree, if the paradigm is shifting, the question is what if any is the next hemodynamic measurement that we would look at, because I do agree that doesn't seem completely logical to use the systolic. So that's a really interesting point that you guys brought out, and maybe we'll if something comes out as far as literature, maybe we can look at that later. But my other question was, what would you say to people who say that if you're giving nitro, let's say that they've had a lot of, experiences, so that, somebody comes and say, I've had 10 transports, and when I give them nitro, it reduces their pain. So are you going to sit here and tell me that giving nitro, even if it's reducing their pain, isn't helping? That seems counterintuitive if the pain's going away, but it's not helping.
Yeah, I think that's a good point. It's definitely, and as you heard Matt and I talk about, we're weighing out the pros and cons of the complications associated with dropping your preload. And we know, these people have no problem not giving nitro to an inferior wall MI because of the stigma that's been associated with that, when the evidence shows that you're just as likely to have a hypotensive episode from any other MI, right? So, yeah, you could probably reduce the pain a little bit in an inferior wall MI, but nobody's doing that. Now, if you are a paramedic program, I don't know why you wouldn't just give fentanyl. You know what I mean? Like, if you're going to reduce the pain, give something that actually reduces the pain. Now, at that point, you can't say, hey, they don't have chest pain anymore, let's put them on a floor, So
Yeah.
it's kind of predicated on making sure they are continuing that pathway to PCI. But if you're not, like, let's talk about like a BLS service. Matt was, their program, they're within a couple minutes of a cath lab, right? So does it make sense to give them something that could bottom out their blood pressure after one dose? They can't start a drip because, it's a BLS crew, or just take those few minutes and get them to PCI. Now, when you start talking about prolonged transport times, that's a different conversation, and that's not really what we talked about. Matt's got a really short distance to PCI. That's a very subset, right? So you're saying a BLS program that has a 40-minute transport, and even then we're like, yeah, maybe a nitro drip makes more sense. But, or not a BLS, an ALS program that's got a long distance, maybe a nitro drip makes more sense. BLS, and with all this, you gotta follow your guidelines, but it definitely was a good conversation to have, because it's something that I've been thinking about. Dr. Smith kind of validated a little bit more. And then after I heard this, just kind of put the cherry on top.
So I got one more for you, and because I think you guys covered the big points in a fantastic way in that podcast. That was super informative, and it seems very logical. This is a little bit of a futurist thing right here. Okay. So you remember that podcast we did a little while ago where it was all about inotropy, and we were talking about Laplace's law. We talked about the Frank-Starling curve, right? And that was the one, in case you guys are trying to look it up, it was called inotropy is not like a rubber band. I think maybe the blog was called No Rubber Bands, Man, or something like that. And in there, I talked about a peristernal short axis view, like at the level of like the papillary muscles. And with that view, you can look at the radius of the ventricle during diastole. And so I'm posing this to you because you're the ultrasound guru. And so from that, from getting a radius of the left ventricle at diastole, you can take then your systolic blood pressure, which the validity of it is questionable. Maybe let's assume all things perfect. You have an art line, okay?
Getting into
You're
the
very
weeds,
confident in your systolic blood pressure, and you have ultrasound, okay? So you have this beautiful peristernal short axis view. You were able to obtain the radius, and now you have a very reliable systolic blood pressure. Now, what that gives you at the end of the day is a myocardial wall tension, essentially, because you have two parts of the equation, so you can solve for X. Once I have my pressure, I can then take my radius, and that will give me a myocardial wall tension essentially in dynes per centimeter squared. That's a number that we never ever really talk about, like ever, right? And so that's a huge driver of myocardial wall consumption, or myocardial oxygen consumption, is wall tension and heart rate, right? It's like the two biggest factors. How fast is it doing it, and how hard is it doing it? And so do you think that there will ever be some kind of guideline where you can make a very informed decision about whether or not you'd like to give nitroglycerin? Because, you could have rebound tachycardia, you could have all these different issues. Do you think that assessment will ever come into play? The only reason I bring this up is because, remember last time I was like, I don't know what you'd use this for, but I'm throwing it out there into the ether to see if anybody picks it up. Do you think that there's any, I'm talking 10 years in the future, are we going to be using ultrasound and art lines to guide nitro?
Yeah, and I don't think it has to be as complicated as the Laplace's law. Like, I think you could do this just by observing a couple things. So let's say you look, and I'm going to do a parasternal long just to start off. So you look at a parasternal long, and your blood pressure is 180 over 90, and you look and you see that this LV is just engorged with blood, right? And you're going, all right, that's weird. Like we're retaining blood inside that left ventricle. That's increasing the wall stress. And if we could just maybe reduce that afterload a little bit, maybe we could get that out. We could get that blood to start ejecting more. And it's kind of like your skate patient, really, where that afterload is so high. You could look at that and say, yeah, let's give nitro to this patient. Let's drop that. And, we know we have to do higher doses because we want it to affect like the arterial system. And that's like an example where I would be like, this is a no-brainer. And to be honest, you probably wouldn't need ultrasound to tell you that patient needs nitro either, right? So then let's get to like the more like the niche cases where you have a patient whose blood pressure's 110 over 72 on, we'll just say on the automatic blood pressure machine. And you look and you see that you have weak cardiac contractility, and maybe you have some wall motion abnormalities in a certain area. We'll say it's, anterior septal or something. And you're looking at that and you're wondering, well, should I give nitro to this patient? Would they optimize, not from afterload reduction, right? Because we can tell automatically we don't need to reduce afterload, but you're asking, could they improve coronary perfusion if I dropped preload on this patient? So if I drop that preload, is it going to have less tension on the walls, that left ventricular end diastolic pressure? And I think that depending on how much volume you actually see inside of there, and when I say volume, I don't mean like how big the LV is, because that LV could be big from hypertrophy. You're actually looking at the anechoic area within that ventricle. If it's really big, then they may benefit from some reduction in preload, but you're also reducing the coronary perfusion pressure. So I have a really hard time deciding whether I can give nitro based off of that patient. The other one's a real obvious case. The one where your blood pressure is 110s over 70s, I'm probably just going to hold off, and I'm not going to do it either way. I like where you're going with the wall tension and the little.
I'm going 20 steps ahead right now.
Dude, you're living in 2030 right now, man.
Yeah, I just want to go 20 steps ahead right now. I just want to throw that out there, because that's where my brain goes with that automatically when we say, how could we? Because you guys talk a little bit about those niche patients that could benefit from nitro, because surely, a little bit of that, like Matt had said, the chicken and the egg. Is this a case of almost where they're in scape, or the pressures don't have to be so high as to be in that scape for them to have a super weak left ventricle and some dysautonomia, where maybe they can't mount a super strong peripheral vascular resistance, but they have an equally strong left ventricle, and so you don't have a super high pressure, but you also have a super weak left ventricle. And so, they're borderline. They're kind of high, but you're shooting this line between, is this just a weak left ventricle that's causing this, and that we're moving further over into scape, or is this a patient having an infarction and this is the blood pressure I'm seeing as an effect of it. So
Mhm.
I think that as we can, because right now a lot of protocols or guidelines, whatever you want to call them, are very just like this. There's this chest pain umbrella, and some of them kind of get nitro, other ones maybe don't. If you don't have a protocol for it, if you've gotten rid of it, and I think as you start to make that dichotomy, eventually people are going to start saying, how nuanced can we get? Can we make a more informed patient decision based off of that as training gets better? So that was kind of my points I wanted to bring up. Again, I think we leave a podcast not knowing where to go with this wall tension thing that I keep thinking about. But I think there's a lot of questions, and I do agree that the literature is not there, as you guys brought out. The literature is not there on nitro. So is it just one of those things that we do because we can and we've done it for a long time? And so is the pendulum swinging the other way right now, and eventually we come back in the middle and we say, oh, in these select, even if they are a STEMI patient, even in these patients, maybe we see a benefit. And I think it probably could be in those hypertensive patients where it's not SCAPE, but it's hypertensive due to some other issue. Because our hope is that even though you're reducing the general systolic and diastolic blood pressure, you're hoping that the left ventricular end diastolic falls even more, right? So if they're like this and there's not a big gap, you're hoping that as they come down, that gap spreads. But who's to say that's always the case?
Right. Sometimes they're
It
both
could
going
remain
down.
exactly the same, and now there's just less perfusion pressure. Does anybody know the answer to that in the acute pre-hospital setting? I've never seen anybody come out with substantial evidence for that.
Yeah. No, I 100% agree. It's interesting. I talked with Joel Porter. He worked in the cath lab, and I was like, do you ever see them use nitro and like it actually like dilate out the vasculature? Because that was the bill that we were all sold in paramedic school, is that it was going to cause vasodilation. And he said it does, like it does cause vasodilation. But the problem is when you give nitro, you're creating a environment, you're giving a drug that is going to promote the release of nitric oxide from the endothelium. It's not actually going in and dilating,
Mm-hmm.
So it requires like this multi-step process.
Has to be
where
converted, yeah.
It has to be converted, and then it has to leak back out of that endothelium into the vasculature to cause vasodilation. And the problem you get into is, when you got a bunch of plaque and atherosclerosis built up, that nitric oxide is not going to be able to release past that atherosclerosis.
Yeah.
And so you're not going to get that vasodilate, or that, I guess, artery, vasodilation in the coronary arteries,
vascular dilation
in that area. And so that's something to keep in mind, as opposed to like when you're giving something like nitroprusside, where you're actually giving something that has nitric oxide in it.
Mm-hmm. Yeah, no conversion necessary on those. It's like almost like epoprostenol requires, the PGI2 has to go into nitric oxide, or, whatever. These things require conversion, and they have to have access to the inside of the vessels. And so if you have a bunch of junk on the inside of your vessels, I can definitely see where that point is going, because then the conversion doesn't take place, and then what are you honestly doing? The other question I always had, and this is a little bit besides the point, I always thought about, because like you said, the bill of goods that we were sold was that when you give nitroglycerin, it dilates the coronary vessels, and that was proposed as here's the mechanism for nitroglycerin. And maybe it does, if it's right there and the vessels are healthy, which aren't the people that we're dealing with. But I always thought, like, if you dilate these coronary vessels and you're dilating just everything out, I'm like, when you dilate a coronary vessel, the pressure in that vessel goes down. It's almost like septic shock. You think about any form of distributive shock. When you vasodilate, the pressure goes down. So if your point and I'm just speculating here, by the way, this is not, nobody should take this as fact, this is just my brain working through this problem, is that when you dilate those vessels, the pressure would go down in your coronary arteries. And so maybe they got a little wider. Maybe the idea is that it allows a clot to go further down. I'm not entirely sure if that would work very well or not, unless I observed it directly. But I always thought about that, dilate any vessel and the pressure goes down, but your whole point is to keep the coronary perfusion high. So, but then you balance that with wall tension and heart rate. So very complicated question. But until we have to look at all these different complications in the setting of a clinical trial and say, we understand most of these, it's going to come down to patient selection. We understand what most of these mechanisms are. When we take them as a whole and apply them, in a control group and an intervention group, can we demonstrate a difference? And I think that you guys have kind of showed that not yet.
Not yet. Yeah. All right, man. Awesome episode. Matt
Good job,
Schneider,
guys.
thanks so much for coming on the podcast. We'll have him back. I want to start picking the brains of lots of people who have done interesting things to their guidelines and start a series where we talk about this stuff. So I got the guidelines. They're in the show notes. I got Matt's contact, and we'll see you guys next time.
See you guys.